Okay, we are now on staff training and certification requirements, page 11 and 12. This is a new section that we've added, requiring the staff who do the service definition to have certain training, by when, and all that. So we require that all staff be trained in a to be determined support employment 101, whatever that looks like. We're developing that now. That will take that within 8 months of implementation of this policy, or upon each new staff day of hire. So as new people come along throughout the next couple months, if there's a new staff, they have 8 months to take that training. It will be probably a 1 to 2 day training in the models and service definition requirements, with opportunity for continued education and a possible learning collaborative that we would set up through the TAC for each catchment area, so that staff from different providers can also talk about employment and how things are going. The additional training will be developed and required for employment peer mentors on vocational peer support. And that will give peers will have about 12 months from their date of hire to take that training. So we want to allow some time to also build the capacity and build the training that we're in the process of doing. Training also meets nationally accepted professional skills and competencies to ensure high quality services and high outcomes. Every year, staff must also receive 5 or more hours of continued training. And in the definition, you'll see a whole list of recommendations of trainings. Those are not required, but they're recommended based on the approaches and based on other things like SSI work incentives, benefits counseling, SOAR training. Are you guys familiar with SOAR? Okay, so that's one of the good ones that staff can take. So there's a bunch of recommendations in there. The CESP credential. That's the new credential that we are highly recommending all staff in the service definition to take. That demonstrates they have met competencies for evidence-based practices. It may be a requirement later. Right now in the service definition, we are highly recommending that. Why? Because we need to build capacity. We just had the first exam session in the state 2 weeks ago at the NCAPSI conference, and we will be holding another exam session probably this fiscal year and a few more in the next fiscal year. So we need to first build that capacity, and we may make it a requirement once this goes to Medicaid service. So what is the CESP? It's a national APSI, which is the Association of Persons Supporting Employment First. They've established the Employment Support Professional Council to oversee the first national certification for employment staff. So it is national, which is a really good thing. And it also, they earn the CSP, so they could put that next to their name. They have, they put it on their resume. They have a higher advancement in really engaging in that support and fidelity that we're looking for. And we're sponsoring the exam sessions through our DOJ funding through the TAC Center. So program fidelity monitoring. All programs will be evaluated to a standardized fidelity measure from the approaches outlined in the definition. We're in the middle of developing what that looks like, and it will be tailored to the population served. This is not a requirement, but we as our division, our staff with the TA Center, we will be going to providers and sitting with them and doing a fidelity screening and seeing how they're doing, really helping them with clinical stuff as far as the service definition goes, and the evidence-based approaches. So that way we could also tailor trainings and get quality improvement feedback. So that's a function we will be doing. You guys as an MCO will still be doing provider monitoring and that kind of thing per the service definition. And we'll be working together throughout so that you can know how things are going and what we're hearing and what kind of feedbacks we're getting from the providers themselves. Any questions on that? Okay. Service type and setting. Employment staff typically spend 65% or more of their total scheduled work hours in the community. Okay, this is not a facility-based service. They can have an office somewhere, could be anywhere, but we expect people to be in the community. And services are provided in the most integrated setting, of course. And so this is another evidence-based model in making sure that people are going out to the people in the community. They could go to the person's apartment, they could go meet them at Starbucks, they could, do community-based type of training and looking for work and those kinds of activities. So what are some of the other things? So they're provided at the job location, home, or community setting. Services are not provided in facility-based settings or affirmative industries. That's where we talk about those set-aside type of jobs. So who is eligible? Individuals age 16 and over with mental health, substance use, or IDD, including autism or traumatic brain injury. They have experience in some area of functioning, or they've had some recent crisis intervention or diversion, or are at risk of placement in a more restrictive setting. So this also applies to our DOJ folks coming out of adult care homes and hospitals. And the person expresses a desire to work or has an established pattern of unemployment or underemployment or sporadic employment. So underemployment means what? What does underemployment mean? They work 5 hours a week and they want work more. Sporadic employment, they may have had one job here and there. It's not consistent. They want something better. And the person also requires assistance to obtain employment. In addition, what's typically offered by an employer. Some people are able to get a job and get the supports they need by the employer, and they don't really need a lot of additional one-on-one supports, but some people do. So we want to be conscious of that. The entrance process. So per the evidence-based model, there's a zero exclusion criteria. That is pretty new to a lot of the providers and MCOs, you know, that we've talked to a lot of people, and we're familiar with that if somebody has a substance abuse problem, they will have to get clean for 6 months before they think about work. That doesn't apply here. So individuals are not excluded as a result of job readiness factors, such as active substance use, criminal background, violent behavior history, cognitive impairments, medication noncompliance. Maybe they're not taking their meds, but they really want a job. That's okay. What happens is that this evidence-based model really works with the person where they're at and helps them realize what you need to do to get this job. What does the employer need from you? You got to pass a drug screening. So what do you need to do to get clean? You know, you have to, there's a criminal background check. What are we going to do about it? So you don't stop the employment search to get that person ready to do that. You start working on them and thinking about, okay, what employers are available in the community that we could bypass some of these things, or, you know, do we have to get an expungement from the court about your criminal background? You know, so the staff really work with the person to make that achievable. So we don't wait for people to get ready.
So does the WOOD program assist with the legal fees to get something expunged so that this person would know?
That would be on the provider.
The provider would have to pay for the,
Yeah. And it's
or whatever is needed from the employer.
right. It's about exploring what the options are. So if you need $100 to get that expungement or something, we got to look at either if the provider can fund it or somebody at the community program can fund it. Question? No? Okay. The other thing is collaboration with behavioral health services. We want to make sure that the individual, we know where they're receiving any other services and we're communicating with them. Employment specialists also offer to help with another job when one has ended, regardless of the reason that the job ended or the number of jobs held. So a question that came up is, what if somebody keeps getting a job, losing a job, getting a job, losing a job, getting a job, losing a job? Do we keep helping them or not? It could be either the placement wasn't right, or maybe we as employment staff didn't do a good job, or maybe the person has other issues happening in their life, you know, family, you know, money, something else. So we really need to explore that. So we don't just stop just because they've been unsuccessful. We have to keep trying. So this is where we're really going to track what provider outcomes are based on the individuals that they serve. So whether the provider is allowing or getting outcomes in competitive employment. So we're going to be tracking this data, and all the providers that do the service will track this data based on a new spreadsheet we'll be offering to them, that they'll track how many hours they're working, what's their employment status, 30 hours, part-time, etc., hourly pay rate, what wages they earned the last month, hours in the past month, entitlements received at entry, and entitlements received at 12 months of employment start date. That's kind of to gauge if they're getting off of benefits or something happening to benefits, or if they're gaining employer benefits like vacation leave and things like that. Whether they're eligible for the Medicaid Buying program. Are you guys familiar with that? Medicaid Buying? There's a Medicaid Buying program in the state. A lot of people don't know about it. So we need to, that's another education piece that we really need to send out there to individuals and their families also. You can earn a certain amount of money over the federal poverty level and still keep your Medicaid. A lot of states have this. Some states have a bigger amount than others. I don't remember what the amount is for North Carolina, but there's a certain range that you can earn up to this amount and still not lose your Medicaid. You could lose your money part of your benefits, and that's fine because you're earning more money now with work, but you don't lose your insurance, which is what pays for medication and things like that. That's usually the scary part. So that's available in North Carolina. And so we're going to track whether people are being informed of that or have access to it. Okay, so documentation. It's much longer in the service definition. This is just kind of the brief version of it. But every day of service, you'll write a note, typically how services are done. You can also keep an activity log to measure the number of visits in a given month. So some providers find this as a really good tool. They keep like a monthly calendar, and they X out number of days they work with the person and we're helping the person. That kind of gauges how intensive and less intensive the services are becoming. There's an initial employment plan within the first 30 days that the staff will write with the person and with members of their support network if applicable. And they update it as needed, and they include information such as number of employer contacts for the person on the person's behalf, discussions about disclosure issues, accommodations that the person discussed, any previous services that they had. So there's an array of things that we describe in the service definition that are recommended for the documentation. So it's hopefully clear to providers how many things they should be documenting. We don't expect just that little one service note and put it away. We really expect this to be a working plan and a working document that's integrated with the other plans in this person's life. They might have PCP, CCAs, all this other stuff. This needs to be part of all of that stuff. Okay, utilization management. One of the new things that we did is we realized that there's a problem when providers are transitioning from support employment or long-term support, or from VR to long-term support and things like that. So we wanted to allow for a no prior authorization period for the first 64 units. This is to allow that transition to happen, and then the approval authorization starts to happen. So that's for the initial engagement. This is also really good for transitioning for schools, for anyone that is in a workshop type setting or in other settings that is not so sure, and you kind of have to do that engagement piece. So that's a really useful part. And then authorization for continued services occur and cover up to 12 months, because we know it can take up to that much to get a person really successfully integrated into the Support Employment Services program. So some of the service exclusions and limitations for the service: you can only receive this service from one provider at a time. That's usual. Phase 1 from this service cannot be provided to individuals open in VR or actively receiving support employment from VR. An individual referred from VR to the service can receive the long-term support phase, so they could kind of jump in at that second half, and the support professional can help them where they're at and what they need. The service delivery can include individuals other than the recipient only when the activity is exclusively towards the benefit of that recipient, such as a small business model. So if the person has a small business, they have a business plan, part of it involves their partner in the business, that can be provided for them as a business. And you cannot provide the service at the same time as ACT or Medicaid Innovations Waiver Support Employment for IDD. But it can be provided to anybody in a CST or PSR or any other program, as long as it's not duplicative of what's provided in that program. Any questions on that? What if somebody comes to you and says, I want employment, support employment only, I don't want any other services? That might happen in housing. Is that okay? Yeah. And if somebody's in CST and they've never even thought about support employment, the peer mentors can engage them. Or even the employment staff can meet with the CST team and say, hey, you want us to do a presentation at your agency about support employment and how we can work together. So that would be a really good way to engage people. So the cost analysis and the new rate. This is what we have currently on the left. We have the support employment individual, we have support employment group rate, and we have the long-term support. And right now it's $11.21 a 15-minute unit, $44 an hour. So the new service array will be the individual support employment and no group. Okay, we talked about that not being a best practice model. So anyone right now receiving group support employment will need to transition to the individual support employment or the long-term support phase. And so we're going to have the long-term supports as well. One of the things that came up was like, well, it's one definition, but it's two codes. We had to keep it that way for many reasons. One of them was because it would take us about a year to develop a new IPRS code. Second reason is that we need to track people coming from VR and only using long-term support. So we needed to track that specifically, so we decided to keep the codes as they are. That may change when we go to Medicaid, but right now it's going to be that way. And then the rate right now is $56 an hour, $14.22 a 15-minute unit. So it's some difference, but there's a significant increase in the level of provider quality, evidence-based training, and all those things. These are some of the things included in the rate. This is how we came up with that. So we have training costs. We know that people have to take an initial training and ongoing CEUs and all that. So that includes training for something called the College of Employment Services. If you're familiar with CDS or the College of Direct Support, they have an online curriculum that you can take, and it has 6 online sessions on employment strategies that are based on some of the models we've talked about. It also includes costs for Benefits 101 training and webinars that we have some links on the definition on. The online IPS training course. We're going to be providing IPS training for North Carolina locally, but if a provider wants to additionally go online and take the IPS training course on the web, there's a course that they take directly with Dartmouth online, they could do that because it's funded through this as well. Customized employment online staff training. Griffin and Hammis have sessions on self-employment and customized employment webinar. It also includes the cost for CESP exam. So like we said, it's not mandatory, but we really want people to take it because it may be, and so that's included as part of the rate. We also have assistive technology assistance, so we're assuming that at least 10% of the people on the caseload may need some AT equipment, and that's through the NCATP program. Travel costs for staff. We added in increased for rural areas and travel. We do want people to be in the community 65% of the time, so that's going to be a lot of driving and a lot of going to places. Staff technology. Staff should have a portable tablet or a laptop, cell phone, something that they don't need to come back to the office to type notes. Provider national accreditation costs are included, and also staff time costs for their participation in our fidelity reviews. So that when we go to them and we say we want to spend a day and a half with you to screen your program, to see how you're doing, it's funded that they can take time to do that. The long term is supposed to be less intensive, and it's supposed to be not as frequent. It could be 4 times a month, 15 minutes each. It could be 4 times a month, half an hour each. It really depends on the person and what their needs are. And I know that's one of the biggest concerns people have. But we really need to make sure that people are receiving the support employment services that we've outlined in the definition. It's not just, hey, how you doing? You got the job? Great. It really interventions during long-term support. This is really a way to make sure people retain jobs, and also people are thinking about benefits, people are thinking about assets, people are thinking about conflict, not going back to crisis. So it's a little bit more clinical than you would think long-term support is. It's really making sure the person is okay with the supports that they need and they're successful and they're looking for work. That person can also say, hey, have you thought about other options, have you thought about living in the community if they're not? They can engage them and link them to other providers. This is a higher level of what you're used to. So some of the future plans that we have is the IPS model itself, because this integrates it into there, but we're also looking at expanding the IPS model in pilot sites in different areas of the state, specifically for the SPMI population within, nearby, or in close approximation to behavioral health programs. So really testing out how that works to collaborate with the behavioral health services, not just the employment provider over here, but in conjunction or within the program. So we're going to look at expanding that in the next fiscal year. And we're also transitioning to Medicaid. So we need to really be thinking about how the service rolls out, what works, what doesn't work, and then prepare for transitioning to Medicaid funded services. So this is kind of our pilot time. Okay, there may be things we go back and say that's not working. There may be things that say this is working great, let's keep that. And so this was another reason why when it was decided, you have the funding to expand this, they said let's keep it stay funded for now because we really want to test out those things. And then that way it goes to Medicaid B3 as a cleaner service. We've already tested it, it's working. Also, it doesn't clash with the innovations waiver. So we can prepare it so that innovations is also looking at adapting this as the innovations definition. Are any of you guys IDD care coordinators or? Okay, so you'll be a little familiar with that. So right now, if we were to put it at Medicaid today, it would clash with innovation. So you'd have a provider that may offer both services but would have to do it differently because the definitions don't match. So hopefully by then we can make them all the same. And then the service will continue to be provided for IPRS for those without Medicaid as usual. We have a lot of links here for you, and that's it on my part.
I've been in support employment for about 30 years now. I've seen lots of things come and go. I was on the original team that wrote the grant for VR to do the systems change to bring the first 10 support employment programs here. And the excitement about this particular opportunity is probably to the 10th power of that experience, because at that point we had nothing and we were all building it from scratch. Now we have done quite a bit, made a lot of mistakes along the way, but we're at a point where there's an opportunity with this new definition, with the carrot and stick of the DOJ settlement, to push things further and faster, but with more thoughtfulness behind it. So we really thought very carefully about coming to MCOs first and doing it MCO by MCO and inviting you folks here because it has to be a partnership. This isn't the only time you'll ever see us. We hope to engage in a very dynamic process with you to help you figure out how to make this work in a very, very thoughtful way. So I hope that makes you feel a little better. I've seen just about every form of great and terrible supported employment. I've supervised great and terrible. So there are very few horror stories I haven't seen. Shireen and I are the directors of the Technical Assistance Center, and what that means for you is that we can design training to fit your needs. We can also sit with you and help you make some decisions about, geez, we have a large provider network here, but just because it's big doesn't necessarily mean everybody needs to be in this new thing. And I would absolutely caution you to think very carefully about launching this with providers who are well positioned to do it well and who embrace the idea that their staff need to be trained, that their cultures need to shift, and that this is not just Uncle Bob goes out and is the job coach. So we are in partnership with North Carolina Association for People in support of Employment First and the Peer Recovery Network, which is formerly Mecklenburg's Promise, and the division, and we'll go on. We do see this as a partnership. We would like to provide you with any kind of technical support or any kind of training, even designed and customized training that'll help you make this work. We're willing to sit with you as you evaluate your provider network. We're willing to help you write or develop your RFAs or RFI or whatever process you use to make those selections. And we want to help you with the capacity building over the long term, like through the next 5 to 6 years. So this is not a once and done, and it's not an in and out. You have the availability now to say, I have someone who can support us. Let's figure it out. Now, do Shireen and I think we know it all? No. One thing I learned very early on was what I don't know, I hire. So we know people all around the country that can be brought here through coercion or because they owe us something, and get those folks here to help us. So we know Griffin and Hammis, we know Mike Callahan, we know just about everybody in supported employment and can figure out a way to get them here to help you. Our effort will be to, now that's just going to make it worse, our effort will be to engage your community and to help you build the capacity you need, and I'm not going to read that to you because I'll probably choke. One of the exciting things we have planned is in-depth basic training for employment support professionals, where they would be involved for a couple of days face-on-face training. And then for a year, we would engage them in a mentor training program. We're beginning to reach out to you folks. We hope to help you target your stakeholder audiences and engage them. We want to develop the training that's going to underpin bringing those employment support professionals up to par. And there is a 6-month window of opportunity here for people to come on and then get that training. And obviously meet the DOJ requirements minimally now into the next fiscal year when the requirements go up. So we'll go on to the next one. So here are the initial target audiences. Many of you represent these groups. And then we'll go on. These are just our kickoff events. Really, the rubber will meet the road when we meet with you and begin planning what you need. And it'll be very specific to the way Mecklenburg wants to deal with your network of providers and deal with bringing them to capacity. You will have the ultimate input on designing your plan. It's not our plan, it's your plan, and it has to be a working plan. Otherwise, what's the point? We do plan to use a lot of mentor training and train the trainee approaches, and we do plan to do something more in-depth than just fly-by training. So that should be an exciting thing for you. And we can identify topics with you and bring in national speakers from time to time that'll be of benefit to you and to your providers, and hopefully share some of that among other MCOs as well. We're looking at conference venues for a lot of that to take place. We're offering the CESP exam in multiple conference venues, because if you're already sending staff to an event, they might as well spend another 3 hours brutally taking an exam. Why not? And Shireen and I sitting there proctoring them like idiots, you know. There's nothing worse than having nothing to do except watch people take an exam. The CESP has been crosswalked to many national training programs. Back in the slide where Emery was showing you potential training that people could take, that's in addition to what we'll provide. So you know, you really can stretch out and ask folks to take part in training that goes well beyond what we have here. Because every year an ESP will need to have 5 hours of additional professional training. We will be offering these CESP exams in many venues frequently across the state, and we'll also be training local proctors, so that my goal is to be able to offer it in such a way that, say, if you were a proctor, you could set up an exam session and we could have 30 or 40 people sit for it when the demand reaches the point where we can seat that many people. This is a national process, and I've been lucky enough to be one of the directors of the genesis of this project. We started in 2011, and we based it on a role delineation study with a psychometric specialist. There is a 5-topic domain area. Long-term support is a huge piece of it, with all of the protocol for doing it right. And we have already given the exam to 327 people. So it's starting to grow in 11 sessions in 7 different states. We'll be using our outcome data to help us evaluate how the programs are going across the MCOs, and we will be engaging with other partners, including Business Leadership Network, NCARF, and all the others listed here. Okay? So it's about opportunities, guys. I have never been as excited as I am today, except maybe back in 1983 when we started this mess, and there was nothing. So, you know, it's always about a small group of people who come together and then strong communities who push it forward. Mecklenburg is definitely the leader in our state. You folks put employment first on the map. You were first to decide you weren't going to fund the workshops and the day programs at the capacity that you had in the past, and to demand that employment be on the radar with all people. This is the ideal place for us to come together, and we have a chance now to kick it further than we ever had before. My closing thought would be, think carefully. This is not about opening the gate and letting everybody in the barn. This is really about being very selective in a good way and saying, what do the people, the citizens need, and who's best positioned to meet those needs, willing to do the work to bring their staff up to par.
Providers don't need the Gold Star monitoring if they're doing this service definition or ACT, the Support Employment or ACT, because we're going to be doing that clinical fidelity best practice monitoring. It's going to be very intensive. It's going to be, you know, highly clinical, and it has to do with the DOJ settlement. So that's something that Sandy Resnick, I don't know who's communicating on the Gold Star, but that's something we were working on recently to make sure that you guys don't duplicate what we're doing as far as best practices.